Hello everyone. Today we're going to follow the steps of a frameless gamma knife stereotactic radiosurgery case performed in the Center for Image-Guided Neurosurgery at the University of Pittsburgh Medical Center. Here we have shown the Lexel Icon gamma knife unit, which has an incorporated cone beam CT imaging system. Here are the three components that are needed for the mask preparation and fixation. The first is the black mask adapter, the second is the head cushion, and the third is the thermoplastic mask. The mask adapter fits into the gamma knife unit bed, always at a 90-degree angle and locked into place. There are white marks at the top, which define the field of view for the cone beam CT. There are also two white lines, one on each side of the adapter, which will later serve as markers for the head cushion placement on the adapter. The patient enters the gamma knife suite and sits comfortably on the gamma knife unit bed. The head cushion is foil packed and it comes soft and ready to be used because as soon as it is exposed to the air, it begins to set. The foil is opened and water is sprayed directly into the cushion for about 20 times throughout the cushion. We then massage the cushion to work the water through it and then create a pocket in the center of the cushion. Once the pocket is created, the head cushion is placed inside the mask adapter. It is important that the sides of the cushion do not extend up onto the margins of the mask adapter where the mask will later clip into. The patient's head is then placed back onto the head cushion as high as possible, and we start to mold the cushion around the head in order to provide good neck support. It is important to make necessary adjustments to the cushion for maximizing the patient's neck comfort and also to check and make sure that there is some space between the patient's shoulders and the top of the unit's bed to ensure the patient's comfort during the treatment. The cushion must be held in place for approximately 12 minutes until it fully sets in order to get firm fixation and immobilization. While we are waiting for the head cushion to set, the mask preparation can be started. While in the oven, the mask must be with the reinforced side up, so that as it softens, the reinforcement softens onto the mask as opposed to falling away from it. In the meantime, the head cushion will continue to set around the patient's head while the mask has been in the oven softening. The mask is placed into the oven for 8 minutes, and the oven is set to 165 degrees Fahrenheit. A knee cushion is put under the patient's legs and the patient is covered with a blanket. The mask is then taken out of the oven and is placed very gently over the patient's face and then clipped to the adapter on both sides as well as the top. The mask is then pulled away from the patient's nose bridge so that it does not form a pressure point on the patient. The mask is then pressed on the nose bridge and stretched under the chin to make sure that it is under the bone so that the patient's chin will not slip down. In addition, pressure is applied on the mask across the eyebrows and on the orbits, as those bony prominences are also contact points between the patient's face and the mask. There is a 10-minute set time until the mask is fully molded to the patient's head. Once the mask is fully molded to the patient's face and has become hard, the next step is to perform the first cone beam CT. The purpose of this cone beam CT is to provide stereotactic coordinates. The tilt arm and the C arm come into position around the patient's head, and then everyone has to move out of the room. From outside the room, the cone beam CT is performed, and once the first images are available on the machine console, they will be transferred to the treatment plan monitor and they will be co-registered with the pre-plan. The cone beam CT images are now transferred to the treatment planning system console and co-registered with the pre-plan in order to import the cone beam CT coordinates. The pre-plan is based on the MRI scan which was performed early in the morning that day. This is the cone beam CT, and inside the lens is the MRI scan which was performed earlier in the day. The purpose of this cone beam CT is to check around the skull as well as the soft tissue parts to make sure that the correlation between the MRI and the cone beam CT is accurate. Once we are satisfied with the MRI/cone beam CT co-registration, we accept it, and our treatment plan will incorporate the stereotactic coordinates from the cone beam CT scan. Once the first cone beam CT is completed, the camera is positioned into place and the patient is counseled about the use of a call button because once the mask is placed on the patient's face, the patient is not allowed to talk or move the head. In case the patient needs anything, they have to press the call button and then someone will come into the room. A reflective marker is placed on the tip of the patient's nose, and the camera monitors the movement of this marker during treatment, which correlates with head movement. If more than 1.5 millimeters movement is detected during treatment, then the treatment will stop. The patient will come out of the machine, and we will then have to reposition the patient in order to continue the treatment. Next step is to perform the second cone beam CT. The purpose of this CT is to co-register it with the treatment plan and take these final coordinates as the treatment coordinates. The C-arm moves back into position, and the images will appear soon on the machine console. Once these images are acquired, they are transferred to the treatment planning system console for final co-registration with the treatment plan and final stereotactic coordinates. Once we are satisfied with the final co-registration and treatment dose planned, then we sign off the treatment plan and start the treatment. The shielding doors of the gamma knife unit are opened, and the patient is slowly moved back in position inside the unit. While this is being done, we are still monitoring the reflective marker movement at the tip of the patient's nose. By that time, the patient has all the necessary procedural instructions and knows that the head should not be moved during the entire treatment duration. The patient is continuously monitored from outside the room, and according to the rules of Nuclear Regulatory Commission, one authorized medical physicist and one radiation oncologist must be present at the console outside of the room at all times while the treatment is delivered. It is critical to monitor head movement during treatment. In this case, we have set the movement limit at about 1.5 millimeters, and you can see the patient's nose marker is moving, but the movement is below the set limit. If the movement remains within that range, then the treatment will continue without interruption. Once the treatment is completed, the patient is slowly moved out of the unit, and the shielding doors of the unit are closed. The reflective marker is removed from the tip of the patient's nose, and the mask is gently removed from the patient's face by carefully unclipping it from the head adapter. The camera is then taken out from the field, and we assist the patient to sit up in the unit's bed. Finally, the head cushion is removed from the head adapter.